Hello everyone, I'm Maxine from Neuroscience program at the University of Illinois at Urbana-Champaign. Today I'm going to present our work on the clinical validation testing of an upper limb robotic medical education training simulator for rigidity assessment, and I would like to thank all co-authors here. Rigidity is an abnormal motor symptom with increased muscle tone, which is commonly observed in patients with Parkinson's disease. Specifically, lead pipe rigidity produces constant muscle resistance against the passive stretching movement throughout the entire range of motion. The motor portion of the Unified Parkinson's Disease Rating Scale, or UPDRS, is commonly used to qualitatively assess rigidity severity. It has 4 levels, with a score of 0 representing no resistance against the movement as in healthy subjects, and a score of 4 representing severe rigidity at the joint with limited range of motion. Clinicians rely on experience and practical training to distinguish variations within and between conditions, but such experience is limited by the accessibility of real patients. In this study, we present an overview of a novel 1 degree of freedom arm training simulator for rigidity assessment and its clinical validation results. The simulator was driven by a series elastic actuator, and it replicates UPDRS level from 0 to 3. Figure 1b here shows the preferred position of performing rigidity assessment, that the clinician holds the hand of the simulator using one hand and places the other hand to support the elbow. A convenient sample of 11 physicians and physical therapists who specialize in neurology were recruited from OSF Healthcare to evaluate the simulator. 6 participants were scheduled for session 1, and since it was reported that the magnitude of the resistance for each UPDRS level was larger than what they had felt in their clinical experience, the torque values of all levels were adjusted based on their comments. 5 additional participants were scheduled for session 2 to evaluate the rigidity training simulator again after modification. The study involves 3 parts. First, the blinded assessment means that the UPDRS level was unknown to participants, and they were instructed to perform a passive extension test of the elbow joint and assign a UPDRS score for each trial based on their experience. The UPDRS level was then disclosed to the participants in the second assessment, and the participant had to explain why there was a discrepancy in the blinded assessment results, and they were asked to closely examine each UPDRS level on the simulator and provide comments on the realism of the rigidity replication. And lastly, participants completed a post-test questionnaire that contained 25-point Likert questions. The questionnaire was divided into 3 sections to evaluate first the rigidity simulation characteristics for 4 UPDRS levels, second the design aspects of the simulator, and third the usefulness of the simulator as a potential medical training tool. The questionnaire response of rigidity simulation characteristics was presented here. The horizontal dashed line indicates the ideal score of each metric. After torque modification, participants in session 2 reported that the modified resistance magnitudes in UPDRS level 0 and 1 felt more appropriate, and the realism of the simulation metric for level 1 and 2 was also significantly improved, moving closer to the ideal score of 1, which indicates realistic simulation. Responses for other 2 sections from all 11 participants were shown here as well. Design metric scores were normalized to the deviation between the ideal response and the actual score. Overall, participants reported that the simulator is safe and easy to use with adjustable mounting stand, while the noise from the simulator belt system should be reduced. For the usefulness metric, the actual response is close to the ideal response, a score of 5, that the simulator was reported to be helpful for learning and improving the rigidity assessment techniques, and participants were very likely to recommend it to students. This study suggested that the rigidity simulator was able to simulate 4 UPDRS levels closely after adjustment of the resistance magnitude. This device has the potential as a medical education tool and assists in the development of rigidity assessment techniques. Cogwheel rigidity and spasticity will be incorporated into the simulator as future work to help expand the functionality of the simulator for medical training purposes. This study is funded by John Parch's program, and we would like to thank Leo, Neve, and William for their help with this project. Thank you.